This is Dr. Thomas Dayspring, the Chief Academic Officer at True Health Diagnostics, and I am located at the Richmond campus. And I wanted to talk to everyone today about the Rheum-Autoimmune panel, which consists of diagnostic tests for a variety of autoimmune rheumatic disorders. Now, there are very many rheumatic diseases that a clinician may encounter. The ones on the right are degenerative osteoarthritis or the inflammatory arthritis, gout due to hyperuricemia, and those are clearly not autoimmune diseases. If you look at all the other names on the rest of the slide, some kind of very rare, some way more common, that can present with rheumatic complaints. If we zero in on the ones in the middle, they almost always are associated with arthritic complaints, and some of these we see with regularity in private practice. In fact, although some people say, no, I don't see a lot of rheumatic diseases, they really do. And the systemic autoimmune rheumatic diseases, abbreviated as SARD, include rheumatoid arthritis, systemic lupus erythematosus and its subsets, Sjogren's syndrome, systemic sclerosis, better known as scleroderma, or polymyositis/dermatomyositis. And then there is the mixed bag, the overlap disease called mixed connective tissue disease, which is sort of a combination of lupus, scleroderma, and polymyositis. With respect to the incidence, it's out there. There are a lot of Americans suffering from arthritis, some of it degenerative arthritis, but the autoimmune inflammatory arthritides, if you look at the numbers, they're pretty staggering. And remember, there are so many people walking around with symptoms that are undiagnosed that almost certainly have these diseases. And these diseases not only lead to from mildly annoying to severe symptoms, but they can cause deformity and disability and loss of function for so many people. So it behooves us now to recognize this incidence and get out there and make sure we're not missing any such cases. So we are introducing a new panel called the Rheum-Autoimmune panel at True Health. And our panel utilizes familiar rheumatic biomarkers that incorporate disease-associated clarifying markers that so simplify the diagnosis, enabling effective treatment and, if needed, referral plans. You're much more likely to know what you're going to be dealing with the proper type of testing. The panel was developed because it is crucial to have an early and accurate diagnosis of exactly which autoimmune rheumatic disease might be going on. And this means all primary care physicians, non-rheumatologists. We need such a panel for them. And by primary care physicians, I realize many of the people using True Health are often interested in cardiovascular biomarkers, but so many of those patients are going to, unfortunately, have an autoimmune rheumatic disease, and anybody should diagnose this because it even will influence cardiovascular risk. Now, one of the problems with this is historically these type of tests are confusing and challenging for the non-rheumatologist physician. Our panel is uniquely designed for those doing primary care or even mostly cardiovascular care to streamline the diagnosis of these autoimmune rheumatic diseases. And again, I reiterate, if you do diagnose those, they add to whatever cardiovascular risk the patient might already have due to other entities. This is a very powerful slide using carotid intimal thickening to diagnose not intimal thickening but actual plaque in the carotid arteries. And compared to controls, you can see there is a marked increase in atherothrombotic plaque in people with both lupus and rheumatoid arthritis. So again, once that diagnosis is made, their cardiovascular risk elevates to the next highest risk category. In many, it almost makes them a coronary heart disease risk equivalent. And the incidences are not small here, as you can see. So if I have two patients with the exact same cardiovascular biomarker abnormalities and one has lupus or rheumatoid arthritis, they're much sicker and at much higher risk for an atherothrombotic event or plaque than the person who doesn't have these diseases. Even more interesting is that many of the autoimmune rheumatic diseases are associated with abnormalities in the lipid profile. And you see what happens to the standard lipid profile, even the ApoB-A1 ratio, in the various autoimmune rheumatic diseases. Of most interest, and maybe it shouldn't be a surprise, is these are inflammatory diseases. Lipoprotein little a is a reactive hepatic produced protein that in an acute phase situation, the liver will produce more of it, which will elevate whatever the patient's LP little a level was before the disease became present. Now, this doesn't mean it will necessarily push LP little a into the abnormal ranges, but whatever the level is at baseline, be it unremarkable or be it in the higher risk ranges, it will increase as these inflammatory diseases go unchecked. Now, the symptoms that should make a clinician suspicious of autoimmune rheumatic disorders, and all of the ones I'm going to discuss certainly have appropriate ICD-10 codes which need to be placed on an order form. Obviously, joint or muscle pain, Raynaud phenomenon, you know, on exposure to cold, the fingers turn white or have pain associated. Fatigue, low energy is common in these patients. A more serious type of fatigue, I call it failure to thrive, where they just know something is wrong with them. They're feeling ill. There might be some subtle weight loss. Autoimmune diseases are in the differential diagnosis. Certainly, patients, especially women with lupus, can present with neuropsychiatric symptoms. Dermatologic disease is prevalent in such patients, as is alopecia. Photosensitivity is a no-brainer. Wow, I had very little sun exposure, and look at the burn I got. Ocular symptoms, especially dry eyes or lack of tearing, would bring to mind autoimmune rheumatic diseases. Oral ulcers that are of an obvious infectious etiology, if they are recurrent or chronic, you need to consider these diseases. And I throw an interesting real-world scenario out there. Those of us in the cardiovascular world use a lot of statin therapy or lipid-modulating therapy, and one of the more common side effects are musculoskeletal in nature. Now, normally we simply stop the lipid drug, the symptoms go away, you can re-challenge, and it's pretty easy to know is the drug causing it or not. But you all know there are people in the gray zone. They have some vague symptoms before, maybe they were exacerbated with the therapy, or after you stop the therapy, they didn't go completely away. All of a sudden, you have to start looking for other etiologies of the musculoskeletal symptoms, and the autoimmune panel would be an appropriate part of that workup. Of course, there are findings from the physical exam that would alert one that we have to do an arthritic type workup. Obviously, an abnormal joint exam, abnormal muscle soreness or tenderness, muscle weakness, rash, especially the facial or malar rash, any evidence of alopecia or dry mucous membranes in the eye or the mouth. Nodules can occur in rheumatoid arthritis a little bit later in the disease, but they're easily missed or mistaken for other things. And of course, recurrent oral ulcers. Very important, although it's not determined by physical examination, in anybody with persistent or unexplained albuminuria, you must rule out certainly lupus as one of the etiologies. Here are some other reasons why we at True Health developed this Rheum-Autoimmune panel. it's not well known, but the typical diagnostic times for autoimmune rheumatic disease to be diagnosed is up to 5 years. And this is very unfortunate nowadays because many of these conditions do lead to end organ damage in approximately 7 years, and disease-modifying therapies are now available. No longer is somebody destined with some of these diseases to suffer all of the horrific deformities and disabilities that you knew were going to happen in the past before such therapies existed. The reality still goes back that it's not easy for a busy practitioner who's not a rheumatologist to figure out which of these diagnostic tests I need to do. When they come back, what do they mean? The process is time-consuming. Often a clinician has to pull out the textbook or start to realize, geez, what tests are needed. And sometimes that means bringing the patient back. We'll do these tests one at a time, multiple draws, and that's leads to delay in diagnosis. Lastly, once the report in the past has come back, the non-rheumatologist was confused, didn't know what do they mean, what conclusions do I draw, what therapy is needed, is a referral needed? And I think you're going to see as we get into our panel that this is going to be made incredibly simple for the non-rheumatologist. So let's get into laboratory testing in autoimmune rheumatic disease. And this little photo should give you a chuckle, and it sort of underlines, oh my God, I don't want to go there. I don't understand these tests. I think we're going to make it very easy for both the clinicians and even patients to perhaps better understand. Now, realize with respect to systemic lupus, there is absolutely no specific test that you say, aha, end of discussion, this is what you have. SLE is diagnosed related to history, physical examination, and of course laboratory findings that will help you zero in on, is it lupus, is it a subset of lupus, etc. Now, the results on our Rheum-Autoimmune panel will appear in appropriate sections of the report form. And realize True Health Diagnostics provides a whole bunch of biomarkers, and many of you get a variety of cardiometabolic markers, and they're each grouped in certain sections of the report. So the high sensitivity C-reactive protein or C-reactive protein will be reported both in the inflammation and the autoimmune sections of the report. The erythrocyte sedimentation rate right now is in the complete blood count page, but in the near future will also likely appear on the autoimmune section. The rheumatoid factor and the anti-CCP, more on that later, will be listed in the autoimmune section. And of course, the anti-nuclear antibody screening part of the panel will also be reported in the autoimmune section. A little word about anti-nuclear antibodies, or ANA. When antibodies are produced that identify a naturally produced protein as foreign, that's an autoantibody. For some reason, your body is looking at normal proteins that are supposed to be there and saying, uh-oh, we don't like them. And the antibodies potentially attack them. Autoantibodies then start the inflammatory process, causing the body to attack itself. Now, antibodies that target normal proteins within the nucleus of the cell, guess what? They're anti-nuclear antibodies. Antibodies that attack other proteins not in the nucleus are certainly autoantibodies, but they're not anti-nuclear antibodies. Most people, believe it or not, have at least a few autoantibodies in really small amounts. The presence of a large amount of an autoantibody, especially anti-nuclear antibodies, can certainly indicate an autoimmune disease is present. A positive anti-nuclear antibody test means nuclear autoantibodies are present. By itself, it does not indicate the presence of an autoimmune disease or the need for therapy. But when coupled with physical examination findings or a variety of symptoms, the tests become additive to those in making the diagnosis. A positive anti-nuclear antibody is seen in many patients, of course, with SLE, but is not absolute. It's not specific for it. It can be seen in other entities. In fact, depending which study you read, healthy people, so-called healthy people, might show a positive ANA in a small percentage of cases. But those people are not going to have symptoms, physical findings, or other things subjective of the disease. But it's still a rule-out disease. Now, many clinicians are familiar with the fluorescent anti-nuclear antibody test. Rheumatologists often still use it, and it used to be a reflex test when you maybe had a slightly positive ANA and you wanted to do additional studies. So indirect fluorescent antibody is a method in which a person's blood sample is mixed with cells affixed to a slide. The autoantibodies that may be present in the blood react with the cells, and the slide is then treated with a fluorescent antibody reagent and looked at under the microscope. And you will see, or you will not see, and you will see the intensity and the pattern of fluorescence noted. And 4 major patterns have been described, and you see them listed below: speckled, peripheral or centromere, homogeneous or diffuse, and nucleolar. And to the right of those descriptive terms, you see the various autoimmune diseases that might be associated with each pattern or so. First of all, only the rheumatologist has that memorized. Non-rheumatologists are most unlikely to know which are associated with which. So it'd be nicer if we had an easier test to do, and in fact, we do. So what does a positive anti-nuclear antibody test mean? Well, in the top several diseases listed, this is why we did the darn panel, looking for exactly those diseases. But what other things could be associated with a positive ANA? Other autoimmune diseases such as thyroid, not uncommon, autoimmune hepatitis, pretty rare, but chronic infections where the immune system is being chronically stimulated, and of course lymphoproliferative disease where the immune system is at play. Now in those top diseases, you're likely to have certain symptoms which are not likely to be present in those positive ANA-associated diseases at the bottom. So let's look at True Health Diagnostics Rheum-Autoimmune primary profile for autoimmune rheumatic disorders. So if you check off on the order form, this particular panel, it will consist of an anti-nuclear antibody screen, a rheumatoid factor, along with a cyclic citrullonated protein test, and of course the C-reactive protein and erythrocyte sedimentation rate, which are markers of inflammation. Crucial to know at baseline the extent of or activity of the disease, but perhaps even more crucial is a follow-up test to see as to whether any therapeutics that might have been implemented are having an effect on the disease. So you get all of that, but there's going to be some reflex testing involved also. Now let's look at what the report will actually look like when it comes back. And here you see the rheumatic biomarkers that are in the profile. So on this slide, we're going to take away the anti-nuclear antibody and concentrate on the other biomarkers. So the initial part of the report, you see the C-reactive protein listed on top, the other inflammatory biomarker, erythrocyte sedimentation rate, on the bottom, and in between will be posted the results for the rheumatoid factor and the anti-CCP, which we will discuss in depth in a minute. So it hits you right there, and you, of course, will get the actual result, and you will see what the reference interval are. So here's what the erythrocyte sedimentation rate, or ESR, report will look like. You'll get the millimeters per hour number. It'll be flagged as normal or abnormal, and the reference range is a little bit age dependent on what it should be. Very important when you're looking for rheumatic diseases in patients above the age 60 and often older. Any sedimentation rate greater than 60 millimeters per hour should certainly bring polymyalgia rheumatica, giant cell arteritis, or temporal arteritis into the differential diagnosis. And you know, those diseases are crucial to diagnose properly because they're treated and helped almost instantly with the prescription of steroid therapy. So this old-time test is useful in those diseases, but it's a great marker of activity in all of the other autoimmune rheumatic disorders. Let's discuss high-sensitivity C-reactive protein versus C-reactive protein. For autoimmune testing, the high-sensitivity C-reactive protein assay will be utilized to measure the standard reference intervals for both hs-CRP and CRP. It is the exact same assay. The standard reference ranges for both the high sensitivity or the CRP will be reported. Shown in this slide above is how the C-reactive protein, the high sensitivity C-reactive protein, is reported in the inflammatory part of the cardiovascular biomarkers. And shown below is how it will be reported in the autoimmune rheumatic section of the report. Now, of course, with respect to cardiovascular disease-associated inflammation, much lower levels are predictive of that. Typically well under 10, oftentimes under 5. But of course, in an inflamed rheumatic disease, the C-reactive protein elevation will be significantly higher, certainly above 5, many instances above 10. Now, the hs-CRP assay has a wide range of diagnostic intervals. It can measure the very high levels, but it also can measure levels under 4 milligrams per liter, which is the type of inflammation seen with cardiometabolic disease. So the one assay serves both purposes, and for cardiovascular purposes, if ordered, it will be shown in the cardio-inflammatory panel, but of course, in the rheumatic panel, it will be shown with a different reference range. So let's look more closely at the primary profile. With respect to rheumatoid arthritis, the sedimentation rate is currently being reported on the CBC page, but will ultimately show up on this report autoimmune page also. Here is what you will see on the report form. You get the rheumatoid factor, you get the anti-CCP result, and you get the C-reactive protein test, be it hs-CRP or CRP, but you see the reference range for rheumatic diseases. Let's now discuss rheumatoid arthritis, specifically the rheumatoid factor. Rheumatoid factor is produced by the immune system, and it attacks healthy tissue proteins. It is an IgG antibody, rheumatoid factor. The RF test to look for it is assays against a heterogeneous family of IgM antibodies that recognize the rheumatoid factor, which, as mentioned, is an IgG, specifically the Fc portion of the existing antibody. So in reality, the test you're doing to evaluate rheumatoid factor is an antibody against an antibody, or a laboratory antibody used to recognize this pathologically produced antibody. About 70 to 80% of rheumatoid arthritis patients are seropositive over time, and it does increase or is more prevalent in older folks than younger folks with rheumatoid arthritis. And it may indicate a worse prognosis or a more aggressive type of rheumatoid arthritis when the RF test is present. About 1 to 4% of healthy Caucasians in North America, however, may have a positive RF. So again, you want to correlate it with symptoms and physical findings to be 100% sure that rheumatoid arthritis is present. The next test, and it's in the primary panel, that has become essential in diagnosing rheumatoid arthritis is the anti-cyclic citrullinated protein, or anti-CCP test. Now, during protein catabolism, arginine, of course an amino acid component of certain peptides, is converted to citrulline in the catabolic process. At inflammatory sites, meaning joints in this case, the conversion of arginine to citrulline becomes excessive. And when you start changing amino acids in a protein, the shape of that protein, which is now called a citrullinated protein because there's more citrulline in it than there was prior, and when you change the shape of a protein, that makes it antigenic. So antibodies are going to say that's not a normal protein, and they'll bind to it. By the way, citrulus is the Latin word for watermelon. Antibodies to CCP are relatively specific to rheumatoid arthritis. Thus, it is useful in conditions that mimic rheumatoid, such as Sjogren's syndrome, chronic hepatitis, and which could be associated with rheumatic symptoms, or other autoimmune diseases like cryoglobulinemia. The anti-CCP test may define early and aggressive rheumatoid arthritis prior to even a rheumatoid factor being positive. So you really need both RF and anti-CCP to be better able to diagnose rheumatoid arthritis. In fact, if you look at the sensitivity and specificity of rheumatoid factor or anti-CCP, or if you're doing both, the specificity becomes incredible. And the higher the specificity, the higher the positive predictive value. In other words, does the patient really have rheumatoid arthritis or not? All right, now let's get into anti-nuclear antibody screening. This particular component of the primary profile will be done on every patient that you order the profile, anti-nuclear antibodies. Now, what exactly is the laboratory doing when a clinician orders an ANA screen? I'm not sure this is well known in the non-rheumatologic community. The anti-nuclear antibody test is actually comprised of a series of antibody biomarkers, any which one of which being positive will cause the ANA screen to be reported as positive. If the ANA test is positive, True Health will report all of the specific antibody tests, which we call a clarifying profile, that were positive, as well as reporting all of the anti-nuclear antibodies which were negative. And this is so crucial for a clinician because depending which may or may not be positive enables you to zero in on either lupus or subsets of lupus. So now let's look at the anti-nuclear antibody screening part of the primary profile. So if it comes back as negative, understand that a clarifying profile has been performed, but since all of the components are negative, you will not see them individually listed on the report. And what are the 11 anti-nuclear antibodies, which if every single one tests as negative, would lead to the reporting of a negative ANA screen? It's all of those. And it's crucial for you to know they all have been done, but they're all negative. So even if you're still suspicious that I need additional workup to go to the next step of autoimmune disease biomarkers, never, ever order those tests again. You don't say, well, the ANA screen is negative, but I really want to get a DS double-stranded DNA or the Smith antibody, etc. They've been done, they're negative. There are other more obscure antibodies that can perhaps need to be ordered, but not these. They're negative. Now, just for some educational knowledge, Some of the antibodies are actually antibodies to various forms of ribonucleic acid, and these are called extractable nuclear antigens, and they're highlighted in red. So I want to go over the facts that I just presented to you so there's no confusion. So if the ANA screen is negative, it will so be reported on the report form. Here I've highlighted it with a blue background. That will not be seen on the report. It'll simply say negative, and the reference interval tells you should be negative. A negative ANA means all of the following anti-nuclear antibodies were negative, even though they are not reported per se. There was no need to order any of these biomarkers again if additional rheumatic workup is pursued. They are negative. Now let's see what you need to know if the anti-nuclear antibody screen is reported as positive. Remember, the 11 anti-nuclear antibodies in the clarifying profile have been performed, but now they're going to be reported because at least one has to be positive if the ANA screen is reported as positive. Some people call these disease-associated antibodies because it helps you zero in on what exactly might be going on in the lupus family. And there are the antibodies again, but now underneath each specific anti-nuclear antibody, I've listed the types of lupus or other rheumatic diseases are typically associated with that particular biomarker. Now, this will be on the report form, so you don't have to memorize, oh boy, Joe 1 antibody means polymyositis or dermatomyositis. The interpretation part of the report form will alert you to that. If we look at now what the report form will look like if the anti-nuclear antibody screen is reported as positive, here I've highlighted in yellow. It will not be yellow on the report form, but positive is different than the normal reference interval, which is listed as negative. But now you will see a listing of all of the 11 anti-nuclear antibodies that are performed. You will see the reference range, which should be negative for all of those. But now, any which were positive, it might be one, it might be more than one, will be listed. So when you have this, you can start to zero in on, this is lupus, this is scleroderma, etc. And also, you see what causes positive, but you also know which ones are negative, so you don't have to reorder the negative ones again because they're negative. This report so simplifies the diagnosis and understanding and future testing of rheumatic diseases. So let's take them one at a time. And the first part of the clarifying profile is the centromere B, or anti-centromere antibody test. And this is used to diagnose a limited cutaneous type of scleroderma, or the Crest syndrome, which you may remember is calcinosis, Raynaud's phenomenon, esophageal dysfunction, sclerodactyly, and telangiectasia, or some component of those. This centromere B test is found in 60 to 80% of such patients, and it's very highly specific. Next would be the anti-chromatin antibody. And this is the nuclear native histone DNA complex. Anti-chromatin immune complexes do bind to the glomerular basement membrane in SLA patients, so it's often a marker of, nephritis is present. It is sensitive and it is specific for systemic lupus, and sometimes precedes the appearance of the double-stranded DNA antibody. Next would be the double-stranded DNA, or the antibody, the anti-double-stranded DNA. This is moderately sensitive for SLE patients. It's almost 100% specific for SLE. A low titer is rarely seen in other inflammatory conditions. And again, it has a strong association with nephritis in lupus patients. Next would be the anti-Jo1 antibody. And when this was first discovered, it was seen in a patient whose name was John. That's where the name comes from. And it is an extractable nuclear antigen, or ENA, as previously discussed. It's an RNA antibody. Joe 1, named after the poor John who had the disease, is a histidyl transfer RNA synthetase, which is found in nucleated cells. Antibodies to Joe 1 bind to epitopes of that enzyme and inhibit its activity. Anti-Joe 1 is a marker for polymyositis and dermatomyositis and occur most commonly in myositis patients who have interstitial lung disease. A negative test does not exclude polymyositis, dermatomyositis, but it certainly helps you diagnose it when it is present. Next in our panel is the ribosomal P, or more specifically, the anti-ribosomal P antibody test. Antibodies against 3 phosphorylated protein, called the P protein components of ribosomes. It's present in a minority, 5 to 10% of SLE patients, but it is highly specific. SLE patients may manifest signs and symptoms of neuropsychiatric symptoms, and anti-ribosomal P can also be very useful in the differential diagnosis of lupus cerebritis. And it can also be seen, less commonly, but can be there in patients with the overlap disease called mixed connective tissue disease. Next on the list is the anti-RNP antibody tests. RNP antibody, ribonuclear protein, recognizes a complex of protein and small nuclear RNA that has been called U1-RNA. It is, if you're doing the immunofluorescent test, associated with the speckled IFA test. It is required for the diagnosis of mixed connective tissue disease. No other extractable nuclear antibodies should be found in such patients. The patients, on occasion, are positive for rheumatoid factor, and these antibody can also be seen in about 30% of people with systemic lupus, but often it hangs around with the Smith antibody, yet to be discussed, or the double-stranded DNA test. The next antibody on the panel, also an extractable nuclear antigen, is the anti-topoisomerase test. SL-70 is a nuclear and nucleolar enzyme that regulates DNA folding. Anti-SCL70 antibody is very specific for diagnosing scleroderma. It is seen in 20 to 30% of scleroderma patients and is highly specific for diffuse disease. Its presence is quite useful in predicting the development of diffuse cutaneous involvement or pulmonary fibrosis. And if you're doing the IF testing, it's associated with the nucleolar pattern. The next antibody in the panel is the anti-Sjegren syndrome-related antigen A. It is a protein, RNA complex, thus it's an extractable nuclear antigen found in the nucleus and cytoplasm in Sjegren's disease and lupus. 70% of primary Sjegren syndrome will be positive, whereas 10 to 60% of those with lupus will be. The cutaneous type of lupus, a very photosensitive disease, can show a positive SSA. It can be found in ANA negative lupus or polymyositis, but rarely in healthy persons. It's also associated with vasculitis, rheumatoid arthritis, lymphadenopathy, nephritis, and leukopenia in patients who do have Sjegren's syndrome. Well, similar but different is the SSB antibody, the anti-Sjegren syndrome-related antigen B. This is a protein RNA complex, another extractable nuclear antigen found in the nucleus and cytoplasm in Sjegren's disease and lupus. 50% of those who have a positive SSA are also SSB positive. Unusual SSB positivity is the much rarer autoimmune hepatitis. It may be found in ANA negative lupus, but rarely in healthy persons, and it is rare with other connective tissue disorders. Next would be the anti-Smith antibody, which is an antibody directed against small nucleolar riboprotein SM. So it's an extractable nuclear antigen, and it was first described in a patient called Smith. It's seen in 10 to 30% of SLE patients, and it's highly specific for and confirms the diagnosis of systemic lupus. The final antibody in the panel is a megacomplex called the anti-Smith RNP antibody complex. And it's just what the name says it is. It's an antibody directed against the complex of Smith extractable antibody and ribonucleoprotein extractable antibody, and it's used to help diagnose SLE. Because it is against RNA, it is also an extractable nuclear antigen. So when you put it all together, and I hope you now have a much better understanding of what an incredible panel this is, what you're getting, and how it simplifies the diagnosis, as well as what you should do about it, these autoimmune rheumatic diseases. You see the SED rate part of the report, you see the rheumatoid arthritis related report, the C-reactive protein, and then you see all of the antibodies that go into anti-nuclear antibody testing. So, of course, you have to care for these patients. So it's so crucial that we make early diagnosis. It's like why you do advanced cardiometabolic testing, because you want to know about those diseases long before some clinical event occurs. With the rheumatic disease, you want to know it long before joint or other systemic organ involvement occurs. And crucial is the cardiovascular and renal part of what can go wrong with these patients. And it also enables you to monitor the inflammatory biomarkers associated with these diseases and judge response to care. Continuing with the care, as providers, we do want our patients who are going to wind up with these diseases to retain an optional function and not be like the old days when the deformities were so horrific. Of course, pain relief is an essential part of the treatment thing, but patient compliance is necessary, and follow-up testing can help us judge who's being compliant and who is not. And of course, diagnosing these diseases way ahead of time, we can counsel a patient on activities that might exacerbate the process, and they will just be much smarter about what they have to do to minimize the effects of these diseases. Lastly is actual disease management, and much of it falls under the realm of the primary care physician nowadays, and of course some of it will be punted to the rheumatological specialist. We have many types of analgesic or anti-inflammatory medications nowadays. In my day, we only had aspirin, and along came acetaminophen, and then finally non-steroidal and other anti-inflammatory medicines. And there are now way more potent anti-inflammatory medicines that have become commonplace, and you see them listed here. Physical therapy is always a desirable part of a therapeutic regimen in patients who are going to develop these diseases, and once they're taught, they can maintain that themselves. But really important nowadays are the disease-modifying anti-rheumatic drugs, DMARDs, which can actually stop some of the end organ damage and deformities that previously were nothing we could do about it. And you know, they're human monoclonal antibodies, hence the suffix UMAB. And these are injectables, of course, and they exist for rheumatoid arthritis and they exist for lupus. So another super reason why early diagnosis is so essential. Many primary care physicians use these medications, and of course some would want to refer to a rheumatology specialist if such a therapy is needed. But whatever, you're not waiting or subjecting the patient to many years of an underlying disease where these therapies should have been used earlier. Well, I thank you very much for your attention during this seminar, and I hope it's enabled you to better understand the disease process and the easy type of diagnostics that are now available.